Okay, why don't we talk a little bit about the use of immunomodulator and biologic therapy, specifically in the older IBD patients. So these therapies have become central to the treatment algorithm for IBD of all ages, either alone or in combination for ulcerative colitis or Crohn's disease. Typically for patients not responding to first-line therapy, or sometimes for those who have responded to steroids, but to use these medications as a steroid-sparing agent. So we know from multiple studies these drugs are able to induce and maintain remission, decrease the need for steroid therapy, and at least for biologics, decrease the rate of hospitalization and colectomy. So with these therapies come a small risk of serious complications. The most concerning serious adverse events with these medications is the risk of serious infection or neoplasia. One retrospective clinical series showed that if you're on either immunomodulators or biologics, your risk of an opportunistic infection was increased by 3-fold. And if you were on both therapies, your risk was increased 14-fold. And in that study, age greater than 50 was an independent predictor of the risk of opportunistic infection.
So, Darrell, what do you do about combined therapy, and how do you associate that with age? Because people who are older are at an increased risk of infection anyway, because the immune response does decrease with age. At least there's some studies suggesting that.
Yeah, I agree. So the way I approach monotherapy versus combination therapy is the same in all patients. You try to risk stratify. How severe is their IBD? What's your prediction of them having complications, disability, et cetera? And the more severe the disease is, the more likely I am to use combination therapy. In the older patients, the older they get, the higher my threshold is for using either of these medications, and particularly to use combination therapy.
You mean you have a higher threshold to use to use two medications?
In other words, they have to be a little bit sicker if they're older to use combination therapy than if they were a healthy young adult.
Mm-hmm. We're always worried in the older population about hidden prostate, breast, uterine cancers being, or having to emerge under the stress of the biologic therapy. I think it's a good point, a good time to talk about vaccinations before we use these therapies, because so many of our patients come in without adequately having been checked for hepatitis A and B. But in the older population, since we can't use live vaccines, once we start with these drugs, the zoster vaccine should be given to them and be pushed ahead of time. Certainly if they're in the conventional therapy range with, say, the 5-aminosalicylates, it's time to talk about that.
Yeah, I agree. So I think that's 2 points that are becoming increasingly appreciated, but still not performed as well as they should, that being cancer screening and vaccination. So I don't do anything different for cancer screening in IBD patients, but I make sure they're up to date with the recommendations for breast and prostate and cervical cancer, et cetera. In terms of vaccination, same thing. Most of the recommendations for IBD patients, even if they're on immunomodulator therapy, is similar to patients without IBD. So we look at their vaccine record, make sure they're up to date. The huge caveat is what you said. If they're on immunomodulator therapy or biologic therapy, you cannot use live viruses. So you have to think about that ahead of time. And if you're going to try aminosalicylates, which are not immune suppressing, that's a great time to make sure they're up to date on their live vaccines. If they need a biologic now because of the severity of their IBD, then I think you have to forego the varicella vaccine.
Mm-hmm.
It's also interesting that we have to recognize the different populations. The demographics are quite different. For example, in the Asian population who harbor hepatitis B, if we don't recognize the fact that they have to be vaccinated ahead of time and we give them the biologic, we have created a lethal situation, literally lethal.
Yeah. Hepatitis B, pneumovax, influenza injection, those are all killed viruses, so they're okay to use those if you're on immunomodulator therapy. Some studies say your response might be attenuated, but most patients, even on steroids or immunomodulators, will have an immune response.
We have to take the extra pains to tell our patients not the nasal flu vaccine. They can't take the viral nasal form.
Yeah, I specifically point that out to each patient. So getting back to the risk of immunomodulator and biologic therapy in the elderly, there's the TREAT registry, which is a large post-marketing survey in patients with Crohn's disease, either on infliximab or not on infliximab. And that showed that neither infliximab nor immunomodulators were an independent predictor of serious infection, whereas steroid use was, and age was a significant predictor of serious infection. In the SONIC study, which looked at azathioprine versus infliximab versus the combination, it's important to note, at least in that study, which of course included highly selected relatively healthy patients, combination therapy did not increase the risk of serious adverse events.
Important to remember, though, that they were usually much younger patients
Yes.
in that study
Yeah.
and with a shorter duration of disease.
Yeah. So that's the problem, I think, with extrapolating clinical trials
Right.
to the clinic where we're taking care of older patients. Some of the more recent studies do not have a upper age limit, or it's 75 years old or something like that. But having said that, they still include very small numbers of older patients. I don't know that any of them actually looked at efficacy or safety in the subgroup of patients that were older. So it's our job to try to extrapolate that data.
But the newer studies, even though they may have an upper age limit, are so sanitized that you can't put someone in with a comorbid disease. So if they have, hypertensive cardiovascular disease, or neurologic disease, or even diabetes, they're not going to get into those studies.
That's exactly right. So actually, some groups have looked at that. There was the Mayo Clinic experience with the first 500 patients treated with infliximab. And in that study, there were 5 out of 500 deaths that were thought to potentially be related to treatment with infliximab. Of the 5 deaths, 4 were older than 65, which is obviously a much higher percentage than the overall population of older IBD patients.
Were they infections?
3 of them were infections. 1 was CLL. So from that open label experience, it suggested early on that age probably was an independent risk factor for bad outcomes with biologic therapy. And then there was this study from Italy, which looked at this specifically. They had a group of older IBD patients over age 65 treated with biologics, compared to an older IBD population not treated with biologics, and a second control group of younger than 65 patients treated with biologics. And what that showed was age was an independent and strong predictor of serious infection and death compared to both control groups. So very sobering information that the risk of these medications is increased in older IBD patients. And we did a similar study at Mayo that's not yet published, but we showed that age greater than 65 was independently predictive of adverse events, and serious infections. So I think as clinicians taking care of these patients, we have to balance the need for therapy, whatever that might be, with the risk of the therapy, which seems to be increased in the older population. And I think that's what makes it challenging.
I'm beginning to think that we need totally different guidelines for the older IBD patient, not just a different paradigm, a different understanding that this is a different biology that we're not appreciating, particularly when we're subjecting them to dual therapy or even multiple courses of antibiotics.
Yeah, and it would be nice to see specific studies with enough older population to do proper analysis to determine the safety and efficacy.
Yeah, and then you'll probably get into what is older. Is it 60? Is it 65? Is it 75? And then some people that are 80 are almost as hale and healthy as somebody who's in bad shape at age 60.
Well, that's why we try and make a distinction between the fit elderly and the frail elderly. I mean, we have people in their 70s playing singles tennis and some people in their 50s who will come in with an aid and a walker. So one size really doesn't fit all.
Yeah.